first of all, like I said, it's fantastic to see 220 people already, just 10 minutes into our stipulated start time. Thank you all for being here. Thank you all for taking time off your valuable Saturday evening. And we hope that by the time this is over, you'll find this time well spent. We have a fantastic faculty here with us. None of them are strangers to all of you. I'm going to begin with Peter first, Dr. Peter Andreka. So let me get this straight. He's a trained certified intensivist. He's a trained certified anesthesiologist. And then he decides to do interventional cardiology. And that not being enough, he then decides to go become general director of the largest hospital in Hungary. He's also the head of cardiology there, head of the intensive care unit. Peter is no stranger to India. His center in Hungary runs one of the most prolific TAVI training programs in the belt. And he's been to India more often than I can remember. Unfortunately, this is the longest spell that we have not seen him. And it's always a pleasure to host him here. And I'm so happy that he's here with all of us. Hi, Peter.
So this first talk will be about the femoral access. I'm not going to be talking about complications, and I'm not going to be talking about very, very difficult cases. I'm trying to be very, very practical with the safe femoral access. You will see, or you may think that this is very obvious what I'm talking about, and this is what we always do. But I think that at the end of the presentation, you will all think that this is probably not the case. I'm talking about myself at the moment, but in the past like 10 years, my radial PCI rate is over 95. It's good, but there's a very difficult consequence of this. So my experience in accessing the femoral artery is getting less and less. So it means that this is happening to the other interventional cardiologists as well. So this is one of the reasons why we are having sometimes a significant femoral artery problems during the TAVI cases. So, but we still think that accessing the femoral artery is simple, and we all know how to do it. But I think that this slide is the most important slide of my presentation, so we gotta be careful, even if we are experienced cardiologists. So here it is very obvious that the femoral regions are not the same. There are ideal femoral region, what you can see on the left side, and there are semi-ideal femoral regions, what you can see on the right side. And the landmarks are, of course, different. So how we access the femoral artery is sometimes different. So this is probably one of the main reasons why we always experience some major vascular complications during the TAVI procedure. But as you can see, it is significantly decreasing with how we decrease the sheath size during the TAVI procedure. But please concentrate on this slide. There's a very strict relationship between the major vascular complications and mortality. So that is the reason why we have to be very, very, very careful during the TAVI procedure. So these are the percutaneous femoral options you can see. The first one is very obvious. This is the surgical cut down. I still think that maybe not significantly, but this is still probably the best option how we can access the femoral artery. However, we have two major problems with that. Problem number one is the surgeon itself. So the cardiovascular surgeons are busy. It is not a challenge for the cardiovascular surgeon to access the common femoral artery, so they quite like sometimes not to participate at the procedures. And there's a very major logistical problem as well. So sometimes it's difficult to get a cardiovascular surgeon to ask him to access the femoral artery. So that is why the full percutaneous access was initiated. We have the ProStar device, which we don't really like. We have the 2 ProGlide system, which is, of course, a bit better. We have the 1 ProGlide system plus the 8 French angioseal, and we have the Manta device. So I'm going to be talking about the second part of the slide. So let's see whether there is any significant difference between the percutaneous access and the surgical access. And if you take a look at the slide, and if you take a deep look at the papers you can find in the literature, so far we haven't found any major significant difference between the femoral artery percutaneous access and the surgical access. However, if we take the minor vascular complications into account, we can see that the surgical access does better. And if we take a look at the hospital stay, we can see that the percutaneous access does better a bit, but we still don't know which one is better. However, if we come to a decision to go for the percutaneous access, we have to be prepared to prevent the vascular complications. This is the iliofemoral screening, or the proper patient selection, the access technique, the sheath and guide wire management, which is very important, the vascular closure device, which is also very important. Please don't forget the operator experience, and how to detect and how to manage complication. This is also very important. We are all aware of this screen. The multi-slice CT is a gold standard how to screen the iliofemoral artery, the vessel size, the tortuosity, and the calcification. However, this is my personal opinion, that since we are interventional cardiologists, and when we do the patient selection, it's always good to go for a peripheral angiogram with a couple of mLs of contrast, which gives us some additional informations. And of course, we have some other tools which we could use, but of course we never use, how we screen the femoral arteries, just like the IVUS. But we have to understand the CT as well. We have to be aware that not only the 3D image, what is important, but as you can see here, there are a lot of additional information in the 2D images, and of course in the stretched vessel view as well. We have to evaluate all 3 together to be able to perfectly screen the femoral iliac system. Here you can see the difference between the ProStar device and the ProGlide device. I think that we all started our percutaneous career with the ProStar device, and I guess that the majority of the interventional cardiologists just stopped using ProStar and we switched to the ProGlide because we think that it's easier to use, and the failure rate of the device, even if in the experienced hands, it's better. Here you can see the new Manta device, which is not a suture-based device.
I think we've lost Andreka.
It's a device, and you can. Oh, you lost me?
Yeah, but you're back. You're back.
I'm back. Okay, thanks. Okay, thanks. Can you hear me now? So anyway, with the Manta device, we can use the access side up to 22 French. So the Manta device can be used for the aortic stent graft systems as well. It is simple and quick to use. However, we have to be really very, very careful with the ACT when we use the device. But even if we are very experienced, we have to be aware of the points of the safe percutaneous access. So we gotta be very, very accurate with the puncture side. with the either the fluoroscopy or the echo guidance and the angulation as well. And we have to be very careful to have the shortest channel during the access. And the picture, maybe many of you know the name of Dr. Zoltán Turi. He's originally Hungarian, but he spent his career in the United States, and he was the one who was very, very careful how to access the femoral artery. These are his original images. This is from the deep femoral era. And we decided to use the modified Turi method, how to access the femoral artery. For that, we are aware of the CT image, and the landmark is the femoral artery. And this is what we can use for the access. But I think that the guidance, the echo-guided puncture, is the safest when we puncture the small sheath side. It is another very important question. A couple of years ago, I found our vascular complication rate is a bit higher than it used to be. And we sat down and looked deeply into the problems. And it was very easy to find out that the majority of the problems happened on the small sheath side and not on the large sheath side. And the reason was very obvious. We were very careful with the large sheath, but we were not so careful with the small sheath puncture. So since then, we punctured the small sheath under the echo, of course, which is very important. And we combine it with the fluoroscopic guidance. We puncture the other side, the large sheath side, under fluoroscopy. We even put a wire down, as you can see, and we can conduct the puncture parallel to the wire. And of course, we always check the position of the sheath after the insertion. So we do a combination puncture technique, echo-guided puncture on the small sheath side and the fluoroscopy guided puncture on the large sheath side, just to avoid the vascular complication on both sides. So overstretching the artery with the sheath. It is another very important question. It is known that if we overstretch the artery more than 20%, it causes a microstructural damage in the arterial wall. And it is the healthy artery. The damage is even more significant if the artery is calcified. So the atherosclerotic artery is more vulnerable if the OD of the sheath approaches or even exceeds the inner diameter of the artery. Here you can see the sheaths and the sheath sizes, what we routinely use for the TAVI procedure. And here you can see the calculated outer diameter of the sheaths. It was calculated by Geza, my friend, who is also well known by you. So if we take a look at the upper part of the screen, you can see that if we take the 14 French sheet, the outer diameter of the 14 French sheet is 18 French, which is 5.95%. And by company, it is suggested to insert a 14 French sheet into an artery which is larger than 5 millimeter. So it means that we overstretch the artery with 16%. And if we take a look at the others, the overstretch is between 16 to 18%. And sometimes, to be honest to you, that sometimes we use an artery which is even smaller than 5 millimeter for the 14 French sheet. So it means that we normally and very routinely overstretch the artery, and we get into the red zone with the seat insertion. So here comes another question. Shall we push the limits even more? So shall we be very definitive and go for only the transfemoral use? And what are those limits which we shouldn't exceed? So if we do that, the entire team should understand why we take the risk with the transfemoral puncture and the transfemoral procedure. So sometimes we have to go for a sequential PTA of the femoral iliac system to be able to insert the sheath and to be able to get through the femoral iliac system. Sometimes we need to stand the artery after the TAVI procedure if it is needed. We always have to check the artery and look for the vascular complication and fix it percutaneously. And we always have to have a vascular surgeon ready to jump in if it's needed. So these are the difficult femoral arteries we have to go through if we come to a decision to go for a femoral access. But sometimes not only the femoral system, but the aortic system can also be very, very difficult. So here you can see that the rate of the alternative access side is getting lower and lower. And we are performing more and more transfemoral procedures. And what is the reason? The reason is that if we take a look at the Partner A trial and the Canadian registry, in terms of mortality, the transfemoral procedures did better than the alternative access site procedures. However, if we take the French registry, there is no really significant difference in terms of mortality between the transfemoral procedures and the alternative access site procedures. But to always be on the safe side, we have to anticipate and minimize the femoral iliac complications during the procedure. We have to be ready for the catastrophic situations. We got to be able to control bleeding rapidly. So we have to have the bailout devices and the bailout experience in the cath lab, Coda balloon for the distal aortic occlusion, crossover occlusion balloons, crossover sheets, peripheral wires and peripheral sheets, and we have to have a significant vascular experience. And I think it is a must. So I have the feeling that a TAVI operator should be trained for the vascular procedures. In Hungary, I'm responsible for the vascular training of the interventional cardiologists, and we decided to convert one part of the interventional cardiologist to peripheral interventionalist as well. And on the top of that, the vascular surgeons should be also available. So the transfemoral procedure favors minimalistic approach. The vascular complications impacts both on acute and late outcomes during TAVI. Patient selection is a key. We have to understand the true outer ID of the sheet, and we have to be able to promptly and acutely diagnose the problem, and we have to be able to solve the problem because we have all the necessary equipment in the room, and we have to have experience how to solve the problems, and we always have to be prepared for the worst. So because of morbidity and mortality and financial issues, to decrease the problems and the logistical difficulties, we, if it's possible, should favor the transfemoral procedures, but we have to be prepared for the difficulties. And today, I think that the interventional cardiologists, especially those who do the structural interventions, should be prepared for the vascular interventions as well. But anything is possible. And if we want to push the limits, we have to be able to solve the complications. And if we think that we have reached the limit, we have to switch to the alternative access site procedure. Thank you very much for your attention. And I think it's great to be interventional cardiologist at this time. And the cardiologists are coming and they are closer than they appear. Thank you very much.
I was just going to read out a couple of comments on the chat. So Louis Fisher has commented that left radial as a secondary access can be also used. So in other words, you go down the radial for one access and then you use the femoral only for large bore access. And in his view, that significantly reduces complications. And I think that's true because you only interfere in one femoral artery. But I think Sushil has already commented, when you go one femoral and one radial, even when something goes wrong, it just slightly increases the challenges of trying to fix the femoral artery again. But I know there are quite a few colleagues have actually switched to that, going radial femoral, and they find that a lot more comfortable. One of the difficulties is that a lot of the diagnostics are done radially, so then you may only have one radial to play with, which usually tends to be the left side of the radial, which then makes it a bit harder for you to reach to the other side and then try to cross over. But yes, it can be done.
I think you have to take into account what that patient's situation is, right? So, for example, I did a case last week in a 90-year-old where we did shockwave. The access was poor. We did a ProStar because the perclosis wouldn't take. Ended up putting a covered stent across that femoral artery for closure, but that was our calculated risk. And I told him that's probably a 30% chance I'm going to put a covered stent because I knew from the CT what my risks were. But we didn't want to do alternative access, which in his case, the only alternative approach we had was carotid. And so, and that would, I know you can do carotids under conscious sedation, but I think we have had good success doing that. We've generally intubated all of our carotids. So we wanted to avoid intubation, wanted to avoid carotid, and we took a 30% risk of a covered stent to do that approach, is what I calculated. But in that case, I'm not going to do radial access for the crossover protection. That's a very high risk anatomy. And so I think it has to be individualized to the patient. And I think your discussions, and I think, 10 years ago, we didn't have these discussions with the patient, but now we have the CT and we know who's high risk vascular access, who's excellent vascular access, right? If somebody has some of these no calcified vessels, no problems, I quote them a very low vascular complication rate. It can still happen, but I think it's low.
Okay. So, Sushil, I'm going to now, Peter, do you want to say something or?
I absolutely agree with all of you. And I have a firm belief that there is not only one truth. And if there is only one, there are several ways to the same truth. But my other firm belief is that if I'm able to hold a linear echo transducer in my hand, we can do anything. So it means that I think it's a very, very important expertise for a TAVI interventionalist to be able to guide his puncture with echo. And then he can guide the contralateral puncture. He can even guide the sometimes the radial puncture if it's needed, or the superficial femoral artery puncture as well, if it's needed below the puncture side of the large sheet. So I think that the key point is the patient selection. But Sushil just told us that he kind of anticipated the 30% risk of inserting a cover stent. Yes, because he was very, very careful during the patient selection period. So I think that this is the key message, that we have to properly screen our patients before the TAVI procedure.
And Peter, you made one comment in your talk that went a little bit quick that I think was right on. And I think one of the challenges, and maybe more so in India than elsewhere, is people are not trained to do caths with femoral access, right? I mean, India is what, 99% radial in most centers.
Yes.
So, the only femoral access that TAVI operators are getting are in the highest risk procedures.
Yeah,
Every other diagnostic every other diagnostic cath is the only percloses they're doing are during TAVI. They're not doing percloses routinely.
Absolutely
so I think
agree.
that becomes part of the challenge in an environment like India. And I think that's something that we have to think about. And you know, whether TAVI operators should do a certain percentage of their caths femoral, even though they don't need to. But you know, in some of these borderline cases, if they're going to do a left main PCI rather than do it radial, do it femoral, where you can justify it to get experience with perclose in smaller sheets rather than only in the 14 and 18 French sheets. And I think, you know, and those operators really can't push the borderline vascular access cases either. They really should take the ideal cases.
Yeah, I guess you are absolutely right.